All right, so this is the fourth video here in this weaning mechanical ventilation video series. So Mr. Rudd has passed his weaning trial and he's extubated to 2 liters nasal cannula. He's alert, is got normal vitals, and he appears to be comfortable. And then 30 minutes later, he comes to Kipnick and his SpO2 is 82%. I assessed Mr. Rudd and observed that he is breathing shallow and rapidly. So we decided to obtain a stat ABG. So additional, acute changes I expect to see with him deteriorating like this would be signs of increased work of breathing. So diaphoretic possibly. He's been working hard on that nasal cannula, trying to adequately ventilate himself. So now he's sweating. I might see retractions, intercostal, substernal retractions, maybe even pursed lip breathing. I know that a lot of COPD patients get coached in that, so maybe he might even be trying to do that, or I'm talking him through that. Tripoding, if he's able to sit up, they sometimes sit up and arms forward on their hands, on their knees to try to assess their breathing and help with that. So accessory muscle usage, and a lot of just fatigue that he's tiring out, and anxiety as well. Because if you just come off a ventilator and you're trying to ventilate for yourself and you're having a hard time, then I guarantee you're going to be pretty anxious about that as well. So when the ABG would return, what would I expect his values to look like after breathing more rapidly? So if he's hyperventilating, normally you would see that they've blown off a lot of CO2. And in this case, I would think that he's not actually blowing off CO2, him being a COPD patient, because he may be breathing more rapidly, but it's shallow, and they already have a dead space issue. So I don't think he's blowing off CO2. I think he's still retaining it because his breaths are so shallow that he's only maybe even not even adequately clearing out his mechanical dead space. So instead of him hyperventilating and blowing off a lot of CO2, I think not only is he retaining it, but he's building it up. So I'd expect his pH to be decreased less than 7.34, which is their normal. So probably 7.3 to 7.29 PaCO2 increased. So their normal would be to 65 at the high zone. So I expect it to be more than that, probably upwards of 70, 75-ish. PaO2 would be decreased less than 55 because he's not oxygenating well. If you're not getting adequate breaths and they're short and shallow, you're not bringing in a big enough breath to ventilate and let oxygenation and gas exchange take place. And I expect his bicarb to be increased because that would be a compensating factor for that. Normally their high is 34, so I'd expect it to be above that. Not a whole lot above that because it would have to, bicarb takes a long time to start really compensating and get it going. So I'd expect it to be 36, maybe 37, something like that. So a respiratory acidosis, if you were looking for a more plain version of what to look at. So would he most likely have acute ventilatory failure on a chronic ventilatory failure, or acute alveolar hyperventilation superimposed on chronic respiratory failure? I think he would have more of a acute ventilatory failure, excuse me, superimposed on chronic ventilatory failure, because it's not an issue of oxygenation that I see. It's that he's not adequately able to ventilate for himself, that he's probably still very weak from being on the ventilator and having to go through all that effort to get past that SBT and weaning trial and to get put on a nasal cannula, that he just had overworked himself already, and that he might have been looking fine, but he was on the verge of having to really do it all on his own, and his body was not able and comfortable enough with doing that. So now as he's beginning to fatigue more, he's taking more shallow breaths, quicker shallow breaths, and not adequately ventilating himself, because normal hyperventilation, as I've kind of alluded to already, would be if I'm hyperventilating, I'm breathing really quick, but I'm taking big breaths with that. So I'm blowing off CO2. But if he's not adequately ventilating either, and he's not getting enough oxygen down to his lung bases, into his lungs to perfuse and start to diffuse into the bloodstream and have proper gas exchange. So it's continuously building on itself, making him increase his CO2, which is in turn going to decrease his pH as well. So after these findings, I discussed with the physician, and he recommends we immediately initiate BiPAP therapy to assist Mr. Rudd in his breathing efforts. So first and foremost, to put him on a BiPAP, you got to put some sort of device to facilitate that, either be nasal prongs or a mask. I prefer a mask, just because with a mask, I know that where that air is going. I know where this is going to. If you have the nasal, if you're a mouth breather and you wear the nasal application, a lot of it could be just going right out your mouth because you're trying to breathe through your mouth, but you need to be breathing through your nose. So all the air and effort's coming through here and coming right back out because you're breathing right back out before it can do anything down deep. So this would be, that's why I prefer the mask. So this is how you size people for a mask. You would take this piece of paper here and put the top up a little bit over their nose around here at the bridge, and you want the bottom to come underneath their lip, not over their chin, but underneath their lip. And a lot of people generally are going to wear like a medium size. Most average people will wear a medium. And if you're super busy and maybe you don't have one of those, maybe this is adequate time. We need to get this man or this woman, especially in this case, Mr. Rudd, onto a BiPAP. I might visibly assess him and grab one size that I think will fit, maybe one size bigger or one size smaller, just in case that doesn't adequately fit. But him being the size that we described, I think a medium would fit him just fine as long as there's no any facial deformities or anything. And that's another issue would be why you pick a nasal apparatus other than the mask would be, maybe they are claustrophobic and they don't want that mask on their face. They won't do well. They'll just have their anxiety will increase even more and they won't be able to ventilate either because now they're claustrophobic. Other reasons you pick a mask over the nasal application is maybe they have nasal polyps, some sort of obstruction going on there that you can't put that in there because it's just going to make it worse. And again, like I said before, they could be a mouth breather. So I prefer the mask always, unless it's indicated that they need to wear the nasal compliance. So initial settings I'm going to put Mr. Rudd on is going to be an EPAP of 5, IPAP of 15. Standardly, you would start IPAP at 10, so 10 over 5, 10 of IPAP and a 5 of EPAP. But since I want him to blow off some of the CO2, I'm not going to start at the normal bit. I'm going to put it at 15, so I know he's going to be adequately blowing that off. And again, with the rate, I'm going to have it a little bit increased because I want him to blow off CO2. So I'm putting the rate at 16 because I want him to be able to blow off the CO2 and adequately ventilate, because this is going to be pushing that deeper into, so he will be getting those adequate breaths, most hopefully that he'll be drawing a good tidal volumes, and I'll be able to monitor that as well. O2 I'm going to put at 28% because I don't see this failure as a hypoxic event. They do have a hypoxic drive, but I don't want to over oxygenate him because then we'll just go into the opposite situation where he's not taking breaths on his own at all because his brain's ventilator saying, I'm getting oxygen. I don't need to do this. I just need to take it easy. So I don't want to overdo that. I can always add a little bit of oxygen if I look at his SpO2 or when I receive his blood gas after 30 minutes of starting him on that BiPAP if it's not adequate. But I'm going to start lower and go higher if I need to, instead of trying to go the other way. I time I set at 1.0. And you can always start adjusting those after the fact. If the IPAP's too much, I can decrease it. If he needs to oxygenate a little better or have some more PEEP, I can increase that EPAP and then increase the IPAP as well, because you want to increase that too if you want to maintain the same amount of ventilation for Mr. Rudd. And then alarm settings, you have high pressure, low pressure, high rate, low rate, minute ventilation high and low minute ventilation, and then apnea. So apnea, generally, we always do around 20 seconds before they'll start kicking into that breath. And I would want a backup rate of 10 or at least for him, even though you could go lower, but I want him to breathe more. So a high pressure, generally with these, you go 10 to 15 over what their peak inspiratory pressure is. So since I don't absolutely know what that is, a high pressure over 40 is not good. At 40 is not good. So I'm setting this high pressure at 40. So low pressure is the same kind of concept. You want to do 10 to 15 less than what their peak inspiratory pressure is currently. So I would want to set the low pressure probably around 10, depending on what his actually was. If it was 25, I would want to do 10. or maybe even lower. But I don't want to put it too low because low pressure can indicate some sort of leak going on. So I don't want it to the point that I'm not being able to assess that I have a leak with the ventilator circuit. High rate, they're already breathing high. So I need to set a tad bit high just because they're at that point right now before. So it's not alarming every moment, but not to a point that I'm being negligent. So I'm thinking high rate of 30 because that's when you're really getting to really tachypnic at that point anyway. And then a low rate of 8. That way, even at the low rate when it's alarming, he's still ventilating appropriately, but I know that he's wearing down. And then a high minimum ventilation, you don't want to ventilate over 10 liters really, but he's already breathing high. So I'm going to set it at 10 liters and adjust that as I have to. And low minute ventilation of 5. 5 is adequate, but he's wearing down if he's starting to only do 5, or he's taking very small tidal volumes, and I want to be able to monitor that appropriately. So speaking of monitoring, how am I going to monitor Mr. Rudd's therapy? So here's Mr. Rudd on his BiPAP. One thing is you can assess the ventilator graphics, but always assess your patient as well. And I would say that first and foremost. So I'm going to monitor him and see, if he's showing even more increased work of breathing, is he becoming more anxiety ridden? Is he sweating, diaphoretic, intercostal retractions, any kind of retractions, accessory muscle use? Am I getting an adequate chest rise and fall with him? Is he taking deep enough breaths? And on that, I can also check the ventilator, see, what kind of tidal volume am I getting? Is he breathing over the rate? Or is he only getting the rate that I've set him at this point? What's his peak inspiratory pressure, so I can monitor and make sure that he's not going to have a lot of airway resistance, and if I need to adjust his alarm values that I placed. Also, look at the graphics, make sure you're not seeing any sort of signs of obstruction, even if the PIP isn't too high, but you can see if there's kind of secretions that he's working through as well. And I'm going to monitor his vital signs, his SpO2, his heart rate, his blood pressure, his respiratory rate. Even though I've got him at a rate, is he breathing over the rate? Is he just maintaining the rate that I've set? And after 30 minutes of putting him on the BiPAP, I'm going to get a ABG to see what his values are now. Are we going in the right direction? Have I blown off some of this CO2? Have I blown off too much, or is he still in the status of failure and I'm not making a dent in what's going on? Is he oxygenating well? Am I over oxygenating him? So that is what I would use to monitor Mr. Rudd as I transitioned him onto the BiPAP.